Yeah, so I will shift the focus a bit away from health to social and economic outcomes in particular, and I acknowledge my co-authors, Jacob Bohr, a PhD student who I supervise at Harvard, Frank Tanzer at the Africa Center, and Professor Marie-Louise Nouvelle, the director of the Africa Center, a Wellcome Trust-funded institution in Matuba, South Africa. So the clinical recovery, certainly, of HIV patients and treatment as prevention effects are well established, but we know much less in real-life settings in sub-Saharan Africa about employment recovery, about recovery of social functioning, and we here in this setting where we have a longitudinal socio-economic surveillance, seeing people in regular intervals, half-yearly, if they're on ART, if they're not on ART, before and after initiation, when they're lost to follow-up. We see them in the community because we have a full community dynamic cohort where constantly people are being registered, coming into the community as migrants or due to birth, and of course die and out-migrate, but we follow up migrants, so we have an overview of an entire community, and we can use that powerfully to look at the economic effects of antiretroviral treatment. And we assess here for the first time the extent of employment recovery of ART patients in a general population relative to baseline levels, which is important because we want some comparison, we want some counterfactual that we can compare the recovery observed on ART to. And this is a community, even though it is in South Africa, a wealthy country within South Africa that is very poor, has 25% HIV prevalence, high unemployment rate, about 2/3 of the population, the adult population, unemployed, and 1/3 of the population at any point in time who are registered as household members in this dynamic cohort do actually not live in the households that we visit and where we follow them up. And when we compare what we do here for the first time to the handful of studies that have been conducted in sub-Saharan Africa on the similar topic, we see that they're all based on clinical cohorts that start essentially when people initiate ART or slightly before that, a few months before initiation usually. And regarding the generalizability of those studies, they're usually quite selected cohorts, specific clinical cohorts or workplace cohorts, and thus do not capture an entire population on ART. They also, of course, do not give us any counterfactual because we see patients who start at some point when they're very sick, and then we observe a trend, a recovery of employment status, but we have nothing to compare that to and don't know if the recovery is incomplete or would even overshoot and be more than complete. And lastly, none of these studies, because they lack the population-based data, can adjust for underlying secular trends in employment, which of course in low and middle income settings can be quite traumatic, with employment situations changing very quickly due to, for instance, a mine opening up which happened in our community, which is an effect that we can completely capture, of course. So we here compare relative to levels of employment 4 to 8 years before people initiate on ART, the recovery of patients in their employment on ART, and we capture all patients independent of their strength of attachment to the workforce and control for changes in local unemployment opportunities. The main outcome of interest is employment status measured in the population surveillance, and the main exposure is time since ART initiation. We enroll in this study all individuals that we observed 18 to 59 years of age. Employment status is measured many times, on average almost 5 times per individual in this large cohort of about 35,000 working age adults, contributing to about 150,000 observations in total, and missingness of person observations is quite low, so only in 8% over the entire 150,000 observations we do not have an employment status value. We merge this population-based data to clinical cohort data from a large public sector ART program in an area where private sector provision of ART is negligible. We match people via first name, last name, South African identity number, and age into the population base. Here in this matching exercise, we identify about 2,000 individuals initiated between 2004 and 2010, lost to follow-up because we observed the outcome in the entire population is low, about 6% overall, because we see people when they're no longer accessing ART, when they die in their households, when they out-migrate, and when they just continue to be in the household but stop ART. So low loss to follow-up, 6% over 6 years. The setting here is in northern KwaZulu-Natal, north of Durban, the city of Durban in South Africa. And this map here shows the Africa Center Demographic Surveillance Area, which is about 430 square kilometers. These little crosses here are the clinics where people can initiate ART. These are primary clinics. ART is delivered via a PEPFAR-supported public sector program that is vertical in structure but attached to these primary care clinics. And everybody enrolled in this entire program here, we can link into the surveillance or try to do that. As a statistical approach, we start with a linear probability model because it's easy to interpret. It gives us marginal effects, rather some odds ratios that are difficult to interpret. But we run, in addition, a conditional logit specification as a robustness check. The exposure variable time since ART initiation, we cut into 6 month in intervals to be able to see the recovery of employment. And we can, since we observe individuals at many points over their life course, before and after ART, many years before and many years after, we adjust for individual level fixed effects, which of course is powerful as an identification strategy because we automatically control for all the time invariant factors that make us special as individuals, that remain constant over time. And in addition, we control for a selected number of time variant factors, survey wave, because we have secular trend, of course, underlying in employment in this area, sex, age, education status, an important determinant both of ART seeking and of employment, of course, month of visit and day of visit. Month of visit to adjust for period trends over a year, and it's actually not weekday but day of visit to adjust for the fact that we are probably, as patients going onto ART, more likely to stop being employed or to drop out of employment shortly after we've received a wage rather than shortly before we receive our income. And we control for second and third order interaction effects of sex, education, and survey wave, and sex, age, and education. Here is the Crude result that sort of foreshadows the proper identified result, and we see here a decrease in employment after an initial stable unemployment rate hovering about 36% by about 1/6 of that level a year before ART is initiated, here at 0.0. Then there is some continued decline in employment trend after ART initiation, and then we see this sluggish, delayed, but near complete recovery of employment by year 4 here on the x-axis, where we start at year -4 enrolling people and observe until year 4 years after enrollment. When we now do the proper regression-adjusted employment trend analysis, this is the picture that a clinical cohort would see. Some trend, some employment recovery that seems to be interesting, but it doesn't tell us a lot regarding what would have happened counterfactually if people would not have suffered from HIV disease and would not have had the ability to go onto ART. So we need some comparator to make sense of this employment trend that we would observe if we pretended that we only had clinical data. And here is the full view where we see people 4 years before they start ART, and as a check, we even look 7 years before they start ART, and we see now the regression-adjusted, more dramatic decline in employment by about 50%, from 36% down to almost below 20%, well, a little bit above 20%, and then we see the increase in employment rate over a 4-year period to close to baseline levels. Now, a question that arises when we look at these trends is there still a penalty in being on ART, in being an ART patient? And we examined that in a study where we match ERT initiators against matched controls in survival analysis and look at after employment loss, either in ERT patients or in non-ERT patients that are matched by sex, age, and education status and time of loss of employment, the cumulative recovery after time of employment. And we see here a significant differential in matched controls versus the ERT initiators, but quite a modest differential. So there is some remaining disadvantage of being an ERT patient versus being a matched control, but it doesn't seem to be altogether too dramatic. So a few other results, we also looked at health gains on ART. We see the immunological and physical functioning recovering quite quickly, and we see that there is a 3 to almost 4 year lag in the recovery of employment status, which suggests to us that there is some long delay in being able, after recovering physical functioning and health, to again find employment in this overall high unemployment community. And we confirm the robustness of our results in sensitivity analysis in a conditional load-shit model, and we multiply impute for employment status non-response and loss to follow-up, as I reported on. So overall, we find nearly complete employment recovery in this community in northern KwaZulu-Natal of 98% relative to baseline rates. Large proportions of ART initiators maintain employment, and those who lose recover almost completely after 4 years' time. Of course, that's a long delay in employment recovery. And of course, when you think about it, the true counterfactual here is, of course, not having ART, in which case almost all of these patients would have lost their employment and health. And we see the trend, how steeply it declines before people go onto ART. Average initiation in this community is at CD4 counts 120. So we see this decline, which of course would have continued to complete unemployment. So in terms of implications, we think we see here a strong additional rationale for expanding treatment access over and above health benefits. We see also an opportunity to capture welfare gains that are currently uncaptured, because in the loss of employment and then recovery of employment, we have transaction costs both to the patient and to the employee. So and to the employer. The employer needs to hire someone else, which is costly, and they need to retrain and create firm-specific knowledge in the person who is newly hired. And the person who has lost employment, of course, needs to spend now 4 years searching until, again, he or she will have found employment, which comes at a major economic loss to households, to communities, and the individual patient. And lastly, we think there is an implication here that potentially the ability to maintain people in employment on ART could be an additional motivator for, in particular, men to access care who in this community seek care much later regarding their CD4 count than women. I want to thank the Africa Center for Health and Population Studies community and staff who contribute, of course, to the data collection and to our work, the Klabisa HIV Treatment and Care Program, which is Department of Health funded, the South African government, and USAID PEPFAR supported, and the Wellcome Trust for funding the Africa Center and continuing to fund the Africa Center in the next quinquennium, and my own funding and Frank Tanzer's funding from the NIH.